Hello everyone, welcome to our new episode of Endotalks podcast. I am so happy to receive today Professor Horace Roman. Of course, you know him, but I will let him introduce himself. Welcome.
Thank you, Adrien. So welcome in my office. And so I'm Horace Roman. I'm surgeon of endometriosis for the last 20 years. I'm university professor in the University Hospital in Rouen, also at the University Hospital in Aarhus in Denmark. I am PhD in epidemiology and a researcher in epidemiology of endometriosis. And I am very happy to be with Adrien and with you this morning.
It's a very special episode, and today I would like us to take us in the shoes of Professor Horace Roman to understand how he sees endometriosis and how he treats his patients. First, can you tell us how you came to dedicate your career to endometriosis surgery?
Yes, I decided suddenly to focus on endometriosis surgery in 2004. After 1 year spent in the University Hospital of Clermont-Ferrand, which was one of the centers of endometriosis at that time. There were only few centers on endometriosis in France and abroad. And I was happy and I was lucky to spend 1 year there and to learn endometriosis from Michel Canis, from Arnaud Vattiez. And at the end of that year, I got back to Rouen and I told to my colleagues, I want to be endometriosis surgeons. And my colleagues were amazed because at that time, the surgeons were having as a goal to become gynecological cancer surgeons or urogynecology surgeons, but nobody was seeking to become endometriosis surgeon because the endometriosis was very few gynecologists were aware about endometriosis. And even me, when I was a resident in the 4th year, I was completely unaware about endometriosis and unable to think about endometriosis in the front of the patient with pelvic pain, catamenial dysmenorrhea, and coming in seeking care in emergency. I was completely unable, and the year spent in Clermont-Ferrand completely changed me the view about this disease.
Incredible journey. And now for our young colleagues that enter now the field of endometriosis in general, not only for surgeons, what would be your best advice?
So I think that for young colleagues are very lucky to start right now because today we have a lot of information about endometriosis, but many things are still waiting to be discovered. So they can start by visiting centers of excellence where they see not only how endometriosis is managed, but also they can understand the philosophy of the management of endometriosis, which is so different from that of the cancer of other gynecological diseases. Also, they can follow e-learnings. They can see a lot of movies about endometriosis, and only on my YouTube channel there are almost 1,000 movies which can be seen, and so I think right now the journey to become endometriosis surgeon is much shorter than my journey 20 years ago.
Of course, we didn't have YouTube at that time. Je vais faire un petit clap pour vérifier juste que ça tourne bien. Comme ça on peut passer, ça tourne parfaitement bien. Parfait, nickel, c'est super. So now let's move on to your publication, the step you've made in the literature in endometriosis surgery. I would like to go to some of the most common keywords that are associated with your name. I would like to use 3 or 4 keywords that came to my mind, and of course to to our mind when we think about your in the field of endometriosis. The first one is functional outcome in colorectal endometriosis. After so many publications, do you feel that now you've been to optimize functional outcomes for your patients today?
Yes, honestly, yes. So I started performing the endometriosis surgery in 2005 with the first year 12 patients with colorectal endometriosis, the year in 2006 13 patients. So a small activity, but at that time the best, the greatest endometriosis departments were doing maybe 30, 40 cases a year. And at that time I was amazed in 2009, 2010 to see that almost all publications in colorectal endometriosis were focusing on colorectal resection, and the results were assessed on the basis of dysmenorrhea, dyspareunia, and chronic pain. So nobody or very few people were looking at what happens with the digestive function. So this thing appears unbelievable for me. So we perform the resection of an organ, and to assess our outcomes, we do not look at the organ, how it works. And I published a first paper in a very small series of 50 cases where I just focus on the digestive function between shaving and colorectal resection. And the paper was published in Human Reproduction. And I received a call from Jacques Donès, who said, your paper is unbelievable. However, there are only 50 cases. So the idea to look at the function appeared very new. And from this moment, I started a prospective database, which is still ongoing in our department now. You know it very well. And we introduced a lot of items and questions about how the bowel works before and after the surgery. And we understood that our surgery should be as conservative as we can, however, as complete as possible. And this opened the field to a different approach, where the radicality is maybe less important than the radicality, which is the major goal in cancer, but cannot be extrapolated to endometriosis. And in endometriosis, the functional outcomes, I think, are much more important, because we perform the surgery in young women, 30, 35-year-old, who have 40, 50, or 60 years to live with our outcomes.
So with your own database, with your own surgical experience, you have now conclusions on how to manage properly these patients. What has contributed the most to your functional outcomes, to your optimized now functional outcomes? Is it surgical techniques, patient selections, perioperative management? What is the most important for you, or is it?
I think all these factors combined are important. So once we understood that we should preserve the function, we started to explore new ways to treat the endometriosis to increase the probability to conservate the last 15 centimeters of the digestive tract. So we introduced in 2009 in our practice the disc excision. Of course, this excision has been done the first time by Nezat brothers in '95, if I remember well. So we did not innovate, we did not discover the disc excision, but I think we have became the department with which developed the disc excision and introduced it in new, in larger nodule. So we tried to catch them with disc excision. For example, we introduced the Rouen technique using a transanal stapler, semicircular transanal stapler. Now we are doing it with the robot. So now we are able to create, to manage a very large nodule of the low and mid rectum by disc excision. There is very rare that actually we carry out a low rectal resection, because you are able to do very large 5-6 centimeter size disc excisions. And of course, this improves the outcome because the rectal ampulla is more or less preserved. Then, of course, the surgical approach should also preserve the nerves of the rectum. It is not enough to preserve the shape if you cut the nerves. So we took inspiration from the experience of the team of Marcello Ceccaroni, who is a very good friend. We have a lot of exchanges, and I think we preserve better the function, and we progressively could decrease the risk of LARS, which is a terrible outcome of rectal surgery. Of course, the perioperative care is very important, and what we do the best with the perioperative care is that we completely stop to performing stoma to prevent the fistula. So we prevent now the fistula, or we detect the fistula very early by a very careful follow-up immediately after the surgery. So today, even in low rectal nodules with large resection of the vagina, we do not longer perform the stoma, and we have observed that the risk of fistula is not increased if the stoma is not performed. So all this knowledge, all this combined approach, I think led to better outcomes. And fortunately, because now in our department we perform 350 cases a year, so with such a high volume, if the risk of complication is high,
yes,
this activity is unbearable.
Yes. So now you've reached like a perfect rates of complication.
But it's not
like you can do better.
The perfect rate of complication is 0.
Of course.
So yeah, we could decrease the rate of complications. Of course, with more than 300 cases a year, we have one fistula maybe every 2 months. But honestly, no patient finishes in intensive care. So
yes,
we do not have a catastrophic situation, because we anticipate 1 day earlier,
yes,
the fistula occurrence, and we create the stoma and we manage it. So I think, honestly, I think our approach has considerably been improved during the last 15 years. And this is thanks to the care to include the patients in a database and to see what's happened.
Yes.
So usually the surgeons who do not have bad database, they have a better feeling about that they are doing, because patients who have complications usually do not longer come to see them. So their feeling is that all the patients who come in consultation after the surgery are doing well or almost well. But when you have a database, you understand that the situation is different, and you can realize which are the factors which impact on outcomes, and you can change them.
Yeah, that's very important. Your follow-up is very long with this patient, and for another keyword, it's very important, it's for fertility. Fertility, of course, for our patients is the major issue when they go through surgery, and for couple, of course. During surgery, one of the major surgical technique that impacts fertility is the management of endometrioma. And I would like here to look at a specific paper that to me has changed the way we see cystectomy in endometriomas. One of your most cited paper is published in Human Reproduction in 2010, showed a direct proportional relationship between endometrioma size and ovarian parenchyma inadvertently removed during cystectomy. Can you summarize the results of this study and explain how it has changed the way you see these techniques and how it changed your practice in endometrioma surgery?
Yes. So this paper was published in 2010 and was written in 2009, January, February 2009. And you have to know that at that time, there were a few centers performing the vaporization of endometriomas with laser, and the majority of surgeons were carrying the cystectomy. So the cystectomy was routinely performed in all the patients having a surgery for endometriosis, whatever age, whatever pregnancy intention. And at that time I was doing, I think, the best cystectomy which can be done, that I learned in Clermont-Ferrand, where the surgeon should identify a free zone, free areas of the endometrioma, and should take care not to strip but to dissect progressively in order to remove only the cyst. And I think in 2008 I was asked to describe this technique for a French journal, and I asked the pathologist to provide me some pictures of histology, and I asked him to explain me what's happened and what are the colors we see on the histology, and he said, but this is the endometrial tissue, this is the fibrosis, and this is the ovary. I said, but the ovary I left it behind. I said, no, here you have a lot of follicles, so you remove follicles with your cyst. And I said, just a moment, I did a very ovarian sparing technique. It should not be my specimen. She says, no, you have always ovaries, because look, there is no cleavage plane between, there is no transitional plane between the fibrosis and the ovary. So when you try to remove, you remove also ovary and a lot of follicles. So, and at that moment there were two papers which were suggesting that the cystectomy may be harmful. A paper of Mario Busaca, who reported menopause after bilateral cystectomy, and a paper of Caterina Ixakustos, who observed that the volume of the ovary decreases significantly after a cystectomy. So we started assessing our outcomes. So in 2 or 3 papers which were published during 2 years, and we realized that when we remove the cyst with the best cystectomy procedure, we always remove some ovary. And of course, when the surface of the cyst is very, very high, this small amount of ovary will result in a big volume of ovary lost. And we also had a look at a lot of cysts, a lot of patients with cystectomy done by our colleagues, where the residual ovary is very small and without follicle. And this had two impacts. First, we started vaporizing, we started treating the endometriomas in situ with plasma energy. And the second was that in very big cysts, where the risk of ovarian parenchyma loss is high by cystectomy, and where the vaporization technically is very difficult because the surface is very large. So in this large cyst, we started doing the sclerotherapy. So beginning with this article, we tried to optimize the ovarian tissue preservation in our patients with endometrioma.
Yeah, that was really a milestone paper in your care of endometrioma. Now, based on your existing data and the existing data in the literature, how do you manage endometrioma during surgery?
Yeah, so we identified several factors which determine our approach. So we continue to do the cystectomy, we continue to do the vaporization using plasma, we do a lot of sclerotherapy. So if you speak only about, so we give up the transvaginal sclerotherapy because we do not do it, we refer them to our aortic department. So in our practice, a young woman with only one cyst, with a high AMH, and with the surgery done of the robot, we can afford to carry out a cystectomy, because with the robot, with the flexible instruments, I think we can follow better the fibrosis. So we can afford to do one cystectomy when we perform the surgery for deep endometriosis. If the patient is young with pregnancy intention and she has several small cysts and ovarian reserve is not very high, we prefer the vaporization if the cyst is up to 5 centimeters, 6 centimeters, because at this volume the cyst may be reversed and may be vaporized in best conditions. When the cyst is very large and the patient wishes to get pregnant, we carry out the sclerotherapy, and the largest series in the literature is published by yourself. And if the patient does not longer intend, is sure not longer intend to get pregnant, we carry out the cystectomy.
I think the most interesting fact is that you carry out all of the techniques.
Yes.
You don't stand on one technique only, and I think it's the most important is to adapt yourself to your patient.
This concerns all the localization. For example, in rectal endometriosis, we carry out in 20% of cases shaving, 30% of cases a disc excision, 50% of cases resections. In endometriomas, I think a surgeon should master all the approaches,
yes,
in order to be able to use the best one for an individual patient.
And this will take us directly to the next step of this interview. It's standardization and education. Those two keywords, I think, go together, because in many of your articles you emphasize the need for a serious standardization in endometriosis surgery. You have published 10 steps protocols, surgical videos, structured techniques, paper. But for some of us, especially young colleagues, endometriosis can be seen as a very complex and heterogeneous disease with unpredictable forms when you go to the surgery. Why do you believe, and how do you believe that standardization can be applied and efficient in our patient with endometriosis?
But you're right by emphasizing that the endometriosis is a heterogeneous disease, and the localizations are various and associated, and it results in very complex surgery. So if you have to do a very complex task, it is always good to have a plan. And this plan will include some steps which are security steps, meaning that they are steps to do in order to avoid to have an intraoperative complication where you can be in big trouble. And for example, for the parametrial nodule, I think to the preventive ligations of arteries and veins entering into the nodule. And then you have the excision steps, so where I try to show how to approach the nodule itself from one side, and so I think that these steps are most important for young colleagues in order to help them to follow a rigorous plan and to achieve a surgery when they do not have a huge experience. And when I speak to patients, I always ask an MRI before the surgery, and I used to read myself the MRI to understand exactly. I need to see the surgery the day before.
Yes.
So the day before, I need to know where is the lesion, how I will do, and to follow my vision. And it's like you ask to a pilot who is a very good pilot to take the plane and to go to New York, but without map. Yeah. It's actually impossible. However, it's a very, very good pilot, so she knows how to drive the plane. So I think the endometriosis surgery is the same. It is not enough to be a good surgeon in order to do a good surgery in endometriosis. And that's why I am very reticent to go somewhere and to perform live surgery on site. So I always prefer to broadcast the live surgery from my center in my patients I know very well. So in this case, I think I do the best job.
Very interesting. And to adopt these standards, one surgeon needs to practice, to understand, to see, to touch. What would be your best advice to a young colleague that starts with endometriosis surgery and wants to learn better? What would be your best advice for him?
It's more or less what I have already said, that if they wish to become an endometriosis surgeon, they have to focus on endometriosis surgery. So I think you can be a good endometriosis surgeon if the endometriosis surgery represents 40-50% of your activity.
Yeah.
So if you do endometriosis surgery from while to while, even though you're very good and talentuous and gifted surgeon, you won't be a very good endometriosis surgeon.
So the volume is important.
The volume is very important,
a team
yes.
that is doing a high volume.
And that's why in 2010 I completely stopped performing surgery in any other disease than endometriosis. And this could be problematic in the university center, where a professor should know everything and better than everybody else. So I accepted in 2010 that I won't be the best cancer surgeon, I won't be the best urogynecologist of my team, but I want to be the best endometriosis surgeon of my team, of the city, and also
my personal advice would be to go and meet the surgeon that you see on YouTube, and that's what I did. I think you should go on site. You should go in the operative room.
Exactly.
That's the surgeons.
That's why you were lucky, and we were lucky to receive you several years ago. And after 6 months working together, we understood that we have to continue to work together for the rest of your life. Then.
Yeah, I think you have to meet the people and see how it's done. We will take some broader perspective to understand better how you see endometriosis. How have surgical advances modified the prognosis of our patient during the last 20 years? Can you bring us back to your first surgery and take us now to your last surgery? How it has changed for the prognosis of our patient, and what is your position?
So, from the theory, I think that the patients are much more lucky to have the surgery now in 2025 than in 2000 or 2005.
Lucky for us.
Because we take care about the nerves. We take care about the length of the resections we do. We take care at their ovaries. And so we are much more, we take much more care to everything. And we are much more experienced. However, when we carry out our comparative study, the patients managed in 2005 to 2010, and you know because you are about to publish, they are doing very well in the majority of cases. So this is very astonishing for me. But for sure, at that time, maybe I was not performing the cases comparable to the most severe cases I do now. So the first sacral roots I started in 2013, 2014. So I cannot compare directly my patients from 2025 to the patients to 2005. But I think, I was thinking about this because I read very recently a book written by an actress from France, and her book compared her story with the surgery done recently with the story of a woman who lived 40 years ago. And their destiny is completely different because the older woman has never had a clear diagnosis, a clear management. So her life was completely upset by the disease and without any treatment, while her life of the woman living now changed after the surgery with a natural pregnancy and so on. So I think I'm sure that patients now are more lucky, and far from more, daughters of women with severe endometriosis are lucky because they benefit from a very early diagnosis with continuous pill. And in my opinion, daughters of women with stage 4 endometriosis will maybe not go up to stage 4 endometriosis too.
Okay, so that was for the past. Now, and to finish, how do you see the future? What do you think research in endometriosis surgery should go in the next 5 years? What are the...
So I think there are at least 2 or 3 directions which can change. First is the diagnosis. So to have an early diagnosis, we need to have biological markers. There are some markers found into the blood. We have the salivary test by Zwick, which is very amazing results. And we were involved, in several studies to assess, to validate these tests. So I think the diagnosis will be maybe done very early and with the prevention measures such as the continuous pill, which may block the progression of the disease of the endometriosis. And this should have an impact on the prevalence of very, very severe case within 20 or 30 years. The second would be the medical treatment. So today we do not know how to treat endometriosis with medical treatment. The unique thing we can do is to block the ovulation, to block the disease as is, to freeze the disease more or less. So this is not a treatment, this is just stop the progression. So I think that the treatment we need is a treatment which work like the chemotherapy, which looks for, or immunologic therapy, which looks for a specific receptor on the cells of endometriosis to destroy them exactly without having contraceptive effect, without having side effects as hormones. So I am sure that within the next year, someone will identify this receptor which can be targeted by the treatment. And the third, and I think about this each time I carry out a deep endometriosis of the parametrium, we need a visual marker like a fluorescein or something like this, similar, which may show the lesions of our lesion, the edges of the lesions we remove. Because when we go, for example, on the sciatic nerve endometriosis, we have a deep nodule on contact with the nerves, on contact with the inferior hypogastric plexus. So we sacrifice a lot of nerves, small nerves, the splanchnic nerves, because we say we have to resect everything. If we leave something, a fragment below and there is a recurrence, it will be very, very difficult to come back. So we are eager, we are likely to do more than required. So we need a marker, visual marker, which can, like the advanced reality, to show us the limit where we have to stop our excision, not to do too much in order to preserve the function. So we come always to the same goal, to preserve the function.
That would be amazing. Thank you so much for sharing your time. It was, for me, very interesting to go in your shoes and see endometriosis. I hope this conversation will allow our listeners, GPs or gynaes, or everyone that wants to do endometriosis to understand better this very strange and complex disease. Thank you all for listening to Endotalks podcast, and don't forget to share this episode with your friends or other colleagues.